Hello guys, I'm Eric. I'm a student PTA with CBD College, and I'm gonna do my patient's case on a total hip arthroplasty anterior approach. So my patient had the diagnosis of total hip arthroplasty anterior approach, pain in the right hip, and presence of artificial hip joint. So my patient is a 72-year-old female. She's not working at the moment and she's living with her husband. The patient presents to therapy after 3 weeks status post THA replacement surgery. The patient likes going to the gym, attending cycling and aerobic classes, going to the movies, going to dance, and watching sports. This case caught my interest because the patient is very motivated to start her therapy and get better so she could go out and dance with her husband. And she's the first patient I work with since the start of her therapy. So after the initial evaluation, they gave the patient to me, and I had to come up with the exercises that she had to do, and just my CI watching me and stepping in case I did something wrong. So, and she was very understanding and that I was a student, and she was happy that I was willing to help her too. So one of the goals that she has is that she wants to wear 4-inch heels so she can be closer to her husband, because her husband is really tall and she's like 5'3". And I thought that was a very unique goal, and that's why I chose this patient, because she's one of the patients I work with since the start. So total hip arthroplasty, also known as a hip replacement surgery, involves replacing the hip joint with artificial components such as plastic, metal, and cement. This surgery has various methods of doing it, like the posterior approach, lateral approach, and posterior approach. And this surgery is associated with certain medical conditions that include osteoarthritis, rheumatoid arthritis, osteomyelitis, vascular necrosis, developmental dysplasia, osteoporosis, and hip fractures. So who's more prone to getting a total hip replacement surgery? It will be people who are older, between 60 to 80 years old, due to the result of getting arthritis or other health conditions like osteoporosis or femoral neck fractures. Another common population will be the former athletes who participated in high impact sports like football, basketball, track and field, gymnastics, and soccer. Just because of the repetitive use of running, jumping, and doing the sport, it will lead to wear and tear to the bones, especially on the hip joint. So they could get it when they're older or when they're younger too. And this condition has been really prevalent in the US and around the world. And according to the American Academy of Orthopedic Surgeons, it is estimated that by 2030 there will be 570,000 total hip replacement surgeries performed in the US annually. Although not always THA could be prevented due to certain conditions like arthritis or osteoporosis, which are not modifiable. There are some ways a person could reduce the risk of getting a total hip replacement. So, two modifiable risk factors that a person could change to prevent getting a total hip replacement will be decreasing the body mass index. So, a higher BMI could increase the risk of the chances of putting too much weight bearing on the lower extremities and could cause the increase of the risk of degeneration of the bones, or it could lead to a fracture because there's too much weight bearing on the lower extremities. And another modifiable factor could be quitting smoking, because smoking has a lot of negative effects in the body, including the degeneration of the bones, the bone density, which it could lead to osteoporosis, and it could lead to impact on the bone healing and the risk of infection on the bones. Okay, so the pathophysiology will be the anatomical landmarks that are involved in a THA will be the pelvis and the femur. So the joint that articulates both bones together is called the femoral acetabular joint, which is where the acetabulum of the pelvis articulates with the head of the femur. And this femur, this joint is a ball and socket joint, which means it has different movements such as flexion, extension, internal rotation, external rotation, abduction, adduction, and it could have circumduction if doing all those movements together. So the anterior approach, the incision is located anteriorly by the greater trochanter of the femur, and it's by the TFL, and then the IT band is split, and the glute medius and glute minimus are detached from the insertion point. So this approach is the most direct approach, and it takes less time to heal than the posterior approach. The precautions for this approach will be no hip flexion passing 90 degrees, no hip extension, and no hip external rotation. Because if the patient does any of those movements, then by the arthrokinematics, then the pelvis could glide forward anteriorly, and it could dislocate the femur from the pelvis. So some common signs and symptoms a person could experience are pain. They will have pain in the area where the incision was, depending whether it's anterior, lateral, or posterior. They will have stiffness in the lower leg, the lower extremity. People will have difficulty walking because they have stiffness on the lower extremity. They will have difficulty sleeping because some people would only be allowed to sleep on certain positions. So like my patient, she had the anterior approach. The doctor told her not to sleep on her stomach because that's where the incision is, anteriorly, and the patient is used to sleeping on her stomach. So she told me it was really hard for her to get good sleep because she's not a back sleeper. So she will wake up several times during the night, and she wouldn't get, like, she's not getting regular sleep. And then finally it could have a mental and emotional impact on a person, because it could be hard for someone to make different changes, such as the way they walk, They will be using an assistive devices. Um, they will have trouble sleeping, and then if they were active before, they will not be able to do sports or work out, and they will have pain and stiffness on the hip and the lower extremity. So it will cause a mental and emotional impact on them. Some patients will get depressed, others will get angry, desperate, and yeah, but we will have to learn to tell them to be patient and educate them on that it's gonna take a while for the for them to get better. So the impact on function. So a person that has undergone a THA surgery will be limited to participate in functional activities. Like I said, they will have trouble walking, they will not be able to work, they will be not able to drive. It will be hard for them to get dressed, to put on pants or shoes. And then physical therapy will address these restrictions by proper gait training. So we will teach them how to use the assistive devices that they have to use, like a walker, axillary crutches, or a cane. And then we'll have to teach them how to properly walk, depending on what, like 2-point gait, 3-point gait, 4-point gait, depending on the weight bearings that they could put on the weight on the leg also. And then we will do therapeutic exercises and manual therapy to increase range of motion, strength, stability. So we will be able to do P-ROM, AA-ROM, to try and get them better. And we will obviously work within the doctor's restrictions and their precautions depending their approach. So the tests and measures that were done in the initial evaluation for this patient was the hip disability osteoarthritis outcome, which she scored at 23.75. Then she got active range of motion hip flexion. In the right leg, she got 65 degrees, and in the left leg, she got 85 degrees. Then it was passive range of motion, hip flexion. On the right, it was still 65 degrees, and on the left, it was still 85 degrees, so it didn't change. Then she got hip passive range of motion abduction. On the right, it was within normal limits, and on the left, it was only 25 degrees. And then hip flexion MMT, the right was not tested due because of the surgical precautions. That's where she got the THA done, so it was not tested. And on the left, she got a 4 plus out of 5. Then she got knee flexion MMT. On the right, she got a 4 plus out of 5. And on the left, she got a 5 out of 5. Then she got tested knee extension MMT. On the right, it was a 4 plus out of 5, and on the left it was a 5 out of 5. And finally, she got tested on glute medius MMT, which she got 3 out of 5 on the right and 3 minus out of 5 on the left. So on the interventions for each phase of rehab, the acute phase will last around 0 to 3 or 4 days, and it will be an inpatient setting. So during this time, we will have to prevent hip flexion contracture, promote early ambulation. We will have to promote weight bearing on the operated leg, and the patient needs to build the strength so they don't have pain when weight bearing. And the hip strength should be at least a 3 out of 5. And we could do that by PROM or isometrics. The subacute phase will be between week 1 to week 12. We will start teaching them how to gait train with an assistive device, regain muscular strength and endurance, work on range of motion within the precautions. So we could start stretching, light stretching, passive range of motion, active assisted range of motion, and do active range of motion. And then the chronic phase will be weeks 12 and after. So usually after 12 weeks, the restriction should be lifted and we could begin working on full range of motion. So passing that 90 degrees now on hip flexion. For the anterior approach, doing external rotation and doing hip extension now. And we will be working we still could work active assisted range of motion, but we want to promote active range of motion and maybe do resistant range of motion and some functional exercises like squats and lunges and stuff like that, depending on the tolerance of the patient and the strength that they have built. So the interventions that were done within the clinical settings that I work with the patient were passive range of motion, hip flexion until 90 degrees, and then passive range of motion, internal rotation. And then we started working on restoring the strength of the hip flexor with the Swiss ball, just going to 90 degrees. Then we did some straight leg raises with the strap. We worked on the quads, the hamstrings. The patient did glute sets because she's not able to do bridges. And then we started working on stability of with the patient. So she started to weight shift, and then she did calf raises, and then we started working on gait training. So teaching her how to properly use the cane because she was using it on the same side as the surgery happened. And then the patient was also on her 3rd week status post of the THA anterior approach surgery. So what I learned from this case is that working on a patient with a total hip replacement anterior approach is that it's a little bit more limited to a posterior approach, because the anterior approach, the patient is more limited to what type of exercises they could be doing due to the different precautions. So it's best to work within those precautions and work on those surrounding muscles as well, and the weight bearing stability, and educating them on proper gait mechanics. If a patient was presented again with the same case, I will know the best approach to treat this patient now and how to perform the exercises and help them and guide the patient through the proper rehabilitation. And yeah, there was adequate research to guide care for this patient because a total hip replacement is one of the most common surgeries that patients get, and it's seen a lot in orthopedic clinics.